Hi, Tim. Just confirming, so we're good to go.
Yep, you are live.
Okay. Welcome everyone. I think I see some people trickling in. I'll give maybe another minute just to let everyone join, and then we'll begin. Okay, maybe in the interest of time, we'll get started. Welcome everyone to the Limelight research webinar. Thanks for joining us this Friday. So just as a brief introduction, the Limelight webinar is a series that's hosted by the tumor section. And the goal of this particular webinar series is to highlight some of the trainee research that's being done by residents through the tumor section. And so we're very lucky to have two wonderful faculty discussants today, Dr. Drummond and Dr. Link. And so we'll start off with them giving a brief sort of introduction about their career interests and path, and then we'll go into three trainees who have submitted abstracts and will be presenting their research this morning. So maybe let's start with Dr. Drummond. So Dr. Drummond is the Director of Neurosurgery at the Royal Melbourne Hospital. And she will, maybe I'll invite you to give a few words, and then we'll go to Dr. Link.
Hey everyone, thanks for having me. This is a great idea, having kind of a trainee lab meeting. So congratulations on having a great series. I was asked to talk about my path and my research, which I decided to tell you about it, warts and all, because I've been a fairly meandering researcher. So I'm the Director of Neurosurgery at the Royal Melbourne Hospital, and research has been a big part of my career. I've done a lot of quality of life research, liquid biopsy, novel clinical trials research, but I started out by doing my doctorate in molecular biology of glioma invasion immediately after I finished my training. And I discovered at that time that I'm a terrible researcher. I really did not enjoy it. I struggled all the way through and just thought, this is awful. Obviously, I changed my mind along the way. And so I've sort of tried to condense a few lessons out of what I learnt from my time in the lab, which eventually, gave me a good basis for my future research career. So I'm not saying don't do it. I'm just saying sometimes it doesn't seem quite what a neurosurgeon should be doing. So from that, I learned 3 lessons. So I'm here to tell you my 3 lessons about research. My first lesson about research is you are a different kind of smart. You're a different kind of smart to scientists, and we need both sides. People who've been in science have a very different way of thinking about data, of looking at problems, to what neurosurgeons do. And so making sure that you are working with people who think of things in different ways to who you do will really help you along. And the corollary of that is that neurosurgeons work very differently to scientists. And so sometimes it's really hard for us to get into research work because in neurosurgery, everything's always urgent. You go through your task list and you get to the end of the day. In research, nothing actually has to be done today. And so sometimes it's really hard to get the motivation to finish the tasks in a timely way. So that's my lesson number 1. Find people who are a different kind of smart. The second one is choose your topic wisely. Choose wisely. The number of young neurosurgeons I see who come in and they say, oh, I'm so passionate about, doing this kind of research. And I'm like, is anyone else here doing this kind of research? Okay, you're not smart enough to do this kind of research on your own. So choose a topic that, although you're interested in it, make sure that someone else who's good at this sort of research is around, or someone else who's a really great researcher wants to work with you on this topic, because I think it's really hard for neurosurgeons to do their research on their own and come from scratch. And sort of related to that is find your team. You want to find people both above you and below you who are much smarter than you and who are able to kind of push the research along. You'll have your own contribution, but you need to find a team of people who are interested in the same thing as you and who have complementary skills to what you do. And once I discovered those 3 lessons and actually started applying them, suddenly I decided and found out that I really do like research. So thanks for listening, and I'm really looking forward to hearing the trainees' presentations.
Thank you. Super wise words. Thanks for that. Maybe we'll go to Dr. Link. So for everyone out there, Dr. Link is a skull-based surgeon at the Mayo Clinic in Rochester, and he'll be our other faculty discussant for today's session. So take it away.
Thanks, Joseph, and thanks everybody who's joined. I also think this is a great idea, a great venue for trainees to present their research. And I would just have to second everything Kate said. I think, unfortunately for her, and maybe for the audience, we're very much the same in that I became a neurosurgeon because I like neurosurgery. I like that job, and I do it full time. And I remember vividly when I was getting to the end of my career, Pat Kelly was one of my mentors when I trained. I trained here at Mayo Clinic, and I really admired Dr. Kelly a lot. And I said, you know, I want to be an academic neurosurgeon, you know, but how do you find the time to do that? He was such a busy clinician. And he said, oh, you want some research time? I'll give you 2 days. You can have 2 days for research. They're called Saturday and Sunday. And I've always kept that in the back of my mind. So that's going to be one barrier, is if you're actually a neurosurgeon, you will find that that takes up a great deal of time. But you can still, I think, make really significant contributions to the field. And I knew early on I could never run a lab. I was never going to be able to write a grant and get a lot of money and be somebody. And over my career here, I've seen a lot of people come and go who have very successfully and very unsuccessfully tried that path. And I don't know what the magic is to make it work, but I think you have to be very thoughtful going into it. And I think if you try it and it doesn't work the way you want, that's not a failure. I think you've still contributed greatly. But I would just emphasize that I think there are a lot of very important clinical questions that we can answer, neurosurgeons can answer. And I think one of the keys, especially for trainees, is think of a question you can answer. So, what's the cure for glioblastoma? Is probably not a question you're going to answer. But can we predict facial nerve outcome after vestibular schwannoma surgery? May be a question you can answer. And one of the abstracts that's going to be presented, I think, is a fantastic example of asking an important clinical question and finding an answer to it. So, and to do that, you have to look at your surroundings. In other words, once you finish training and you're out in practice, if you're in a very busy clinical practice, then you can answer a different kind of question than if you're in a more rural practice, where maybe questions like socioeconomics or social indicators of health or practice patterns in your region become important questions that you can answer. So I think if you can be thoughtful about what you want to answer, I think you'll have a lot of success. One final thing I will say, Kate and I have talked about this because we're both editors of kind of insignificant journals, small journals, is right now, there is, I think, a horrible arms race in neurosurgery among trainees and medical students who want to get in. And so there's all these meta-analyses and systematic reviews of bad literature, which results in bad publications that don't actually answer a question. Similarly, AI has become the hot topic, right? If you could put AI in the title of your paper, maybe it'll get more likely to be accepted. But it turns out AI hasn't solved a lot of the problems that we want to solve. So I would just say be thoughtful about those things. So that's my 2 cents.
Thank you. That's wonderful. That's really, I think both sets of advice very, very important for trainees at the various stages that we have in attendance. So thank you both for your thoughts on this. So we'll move to the first trainee speaker. So Hussein, if you're able to share your slides, I'll introduce you. Hussein Shakil is a PGY5 neurosurgery resident at the University of Toronto. He completed his PhD in clinical epidemiology, focusing on study of outcomes in spine surgery and spine oncology, and he'll be doing a spine oncology fellowship in 2027 at Northwell Health with Dr. Daniel Scuba.
Okay. Thanks very much, Joseph. So at the outset, I'd like to thank Joseph and Dr. Zadeh, as well as the remainder of the organizers for this Limelight session, for providing me the opportunity to share this work. So as Joseph mentioned, my name is Hussein. I'm a fifth-year neurosurgery resident here at the University of Toronto. And this study is primarily looking at epidemiology and outcomes after treatment for chordoma here in Ontario for the last 2 decades. So a bit of background about this tumor. So chordomas, as many of you might be aware, are this rare mesenchymal tumor that has really been described as a 1 in a million tumor. So often derived from remnants of notochord cells. They primarily affect the sacropelvic region as well as lower regions of the clivus, but sometimes can also impact the mobile spine. So one of the challenges with this tumor, which has been described as, expansile lobulated intraosseous masses, is that it's quite invasive to surrounding tissues, which can be challenging from a surgical perspective. So a bit more of a background. Histology subtypes have been described as classical, chondroid, and dedifferentiated, and this histology slide on the right is kind of what is typically seen for chordoma. So as mentioned, the underlying cellular biology of this tumor is such that it can be quite challenging from a local recurrence perspective. So with respect to its anatomical location, it's difficult to access for the first part, but secondarily, it can be quite close to and adjacent to critical structures that cannot be resected from a surgical oncology point of view. So what is typically done for these lesions within the long bones is trying to achieve a negative margin. But for chordomas that are afflicting the clivus and the sacropelvic region, it's often challenging to move away critical structures like the carotid arteries or the neurovascular tissues to achieve this negative margin. So one of the challenges that patients have is high rates of local recurrence. But on the flip side, we have had improvements in surgical techniques and technologies available to us to treat these tumors. So one of the big advances from a skull-based perspective is endoscopic endonasal approaches, which have allowed surgeons to approach these lesions with lower morbidity. And secondly, non-invasive adjuvant treatments such as radiotherapy and techniques for delivery have markedly advanced in the last 20 years, allowing us to deliver high doses of radiations to these tumors, which have historically been described as radio insensitive. And part of the advances in our ability to radiate these tumors is from our ability to provide radiation doses as high as 70 and 80 gray, while still sparing the surrounding soft tissue, which was not quite as possible earlier in the 2000s. So one of the objectives of this study was to look at, given the advances in surgical treatment and radiotherapy technology available, was to look at epidemiology patterns and survival for patients with this rare disease in Ontario. And a lot of this was motivated from the fact that we can leverage the large sample sizes afforded from population health databases to identify large populations of patients with these tumors to better understand patterns of treatment and survival. And moreover, some of the advantages of population database approaches is that we can follow these patients for long periods of time after they receive their treatments to make better conclusions or inferences around what we can expect after diagnosis and treatment. So in this study, we utilize a database that I've been working on separately for identifying patients with metastatic spinal tumors, which is really a linkage that has been done in Ontario for cancer records, insurance claims, and cancer care quality control. So these are the Ontario Cancer Registry, the OHIP claims database, and activity level reporting. And really, Ontario is a unique place to do this kind of study because we are a single payer system where every patient that passes through the healthcare system is really paid for by a single insurance provider. And so we can mostly capture the vast majority of cancer patients passing through the health system using the OHIP database. And from this, we identified a subcohort of patients with chordoma using histologically defined diagnosis codes for chondroid, dedifferentiated classic chordoma histology, which were described earlier in this presentation. So a bit about cancer care in Ontario. So the data from this study was derived from about 14 regional cancer programs listed on the left. And these are largely concentrated within the southern region of the province, but serve actually the entire province of Ontario within a population of about 14 million. And this constitutes data from about 11 adult neurosurgical centers and spine surgical service centers. So we were able to identify a cohort of about 200 patients with chordoma that were diagnosed between 2003 and 2019. The vast majority were with classic histology, and the distribution across the different parts of the from the skull base to the mobile spine to the sacropelvic region are described on the left. So about 50% or 46% from the skull base, 17% from the mobile spine, and 30% from the sacropelvic region. So this was a bit more skewed towards the skull base with respect to other studies that have been published in the past, where people generally find that chordoma is more common within the sacrococcygeal region. And most patients were over 40 years of age, slight male predominance. And we were able to fortunately get capture of patients from all regions of the province, including rural regions and regions of lower socioeconomic demographics. So these were the first set of results for the study. We found that the annual number of cases treated or diagnosed within a given year was about 6 to 21 across the study period. When we looked at an age-adjusted or age-standardized incidence in the diagnoses of chordoma for each year, there was about 1.2 on average new cases diagnosed per year during the study period. And looking at trends across the study period, there wasn't an appreciable change in the rates of new diagnoses across each year. So about annual percent change between minus 1.7% to 6%. So not really significant. And we looked at the different subgroups by skull base and spinal sacrum. We found similar findings about 0.5 new cases per million every year. So when we looked a bit more closely at the types of treatments that were being provided to these patients, we found significantly greater rates of adjuvant radiotherapy and stereotactic radiosurgery provided to the skull base group, and slightly higher rates and significantly greater rates for open resection for chordomas that were afflicting the mobile spine or sacropelvic region. One thing that I'll note in this table on the bottom right is there were high rates of biopsy alone being done for patients with spine or sacropelvic chordoma. And what we suspect is there's high amounts of out-of-province referrals for these patients to get their definitive surgery and possibly post-operative adjuvant radiation. And then when we looked at annual trends with respect to treatment, we did find what was interesting was that patients with radiotherapy there was slightly higher rates of radiotherapy being offered to patients with skull-based chordoma after surgery than comparatively to patients with spine or sacropelvic chordoma. Moreover, the newer techniques such as stereotactic radiosurgery, IMRT, and BMAT were consistently more common within the skull-based group. Overall, this did seem to be, in general, how radiation was approached for the cohort for about 82% of patients. And then we also found that in general, the use of adjuvant radiation was increasing every year. So about 8% increase in the odds of receiving adjuvant radiation as the years progressed within the study. Similarly, we looked a little bit at chemotherapy, which was really not used for the vast majority of patients. Only 8.7% of patients were offered chemotherapy after diagnosis, and we suspect that these patients were presenting with likely metastatic chordoma at first presentation, as median survival was only about 2 years after diagnosis. So a little bit more on the trends of surgery with respect to the different anatomical subgroups. Again, rates of endoscopy were being increasingly used, and there was an uptake by about 38% per year within the skull-based group, and analogously a 41% reduction in rates of open surgery for treatment of skull-based chordomas. But we did not find any significant change in the rates of open surgery for the spine or sacropelvic group. So this is again highlighting this finding. So the adjusted odds ratio of receiving open surgery was temporarily decreasing across the study period by about 41%, and then a concomitant increase in about 38% per year increase in the uptake and use of endoscopic surgery. So when we looked at survival, so median follow-up for the cohort was about 5.5 years after diagnosis, 77 patients, and that was about 37% of the cohort were followed until their time of death. And we found that median survival was about 11.7 years after diagnosis, 5-year overall survival 74%, 10-year 58%, and 15-year 48%. And of note, there was no significant difference in overall survival after diagnosis between skull-based, sacropelvic, or spine or mobile spine chordoma. When we looked at trends in survival, so as mentioned earlier, even though there's an increase in the use of endoscopy or adjuvant radiation, we didn't find any significant difference in the actual expected survival after diagnosis across the study period. Overall, older patients had a higher rates of death after diagnosis, which was not unexpected, hazard ratio about 6.04, and no significant difference in the expected or rates of death between anatomic subgroups. So comparing skull base, mobile spine, or sacropelvic, the rates were roughly comparable. And this again demonstrates the comparisons between the different subgroups. So skull base, mobile spine, and sacropelvic chordoma had similar rates of mortality after diagnosis. So in summary, chordoma is a rare disease with stable annual incidence in Ontario between 2003 to 2019, about 1.2 cases per million. Treatment modalities seem to vary by anatomic location, slightly higher use of radiation for the skull-based chordomas, and have transitioned towards more use of endoscopy in the last 2 decades. We found similar survival by anatomic location, and median survival overall was about 12 years in our cohort, which was exceeding prior reports that have been described using the SEER database. So I think some of the major limitations that I did want to address and sort of points of discussion would be around the limited availability about dosing and specific fractionation schedules that were provided to these patients. As well, there was limited availability of postoperative imaging, which would provide better understanding about the extent of resection used for the different types of surgeries, whether patients received what's called an Enneking appropriate or inappropriate surgery for their spine or sacrooccipital chordoma. And this kind of also limited our ability to look at recurrence or progression-free survival after treatment. Moreover, I think an important next step would be to link this type of data to quality of life outcomes, and specifically patient-reported quality of life outcomes, to make sure that quality of life is also improving as the years of treatment go on, and to make sure that our different modalities and technologies are actually improving patient-reported outcome measures in addition to just overall, in addition to maintaining overall survival. Moreover, sort of next steps would be to look at molecular and epigenetic data, which a lot of work has been done by the Zade lab with this particular pathology, and maybe possible cross collaborations would be helpful. And in general, out-of-province surgery and radiation treatments were not available to look at. So questions about whether or not patients receive proton beam therapy as the years went on, which is not available in Canada, would be something that we'd be interested to look at in the future. So I'd like to thank again the tumor section as well as the Limelight initiative for the opportunity to present this work, and all the different collaborators for this project. And I look forward to discussing maybe each of your experience in Rochester and Melbourne to see what you guys found in terms of treating this disease.
Thank you, Hussein. Great presentation. I think we have time for maybe one question. So Dr. Drummond, Dr. Link, to fight it out.
I was unmuted. I think this is great research. You know, it's really important to pull this together, and you've nicely outlined what the problems with the data are, which it is what it is. But you know, for Melbourne, where, you know, if it's a case per 1.2 million, and we've only got 26 million people in our massively big country, you know, the same problem is pulling that data. Where does it go from here? Like, how do you use this? So you've got some interesting trends. You're thinking, you know, that treatment is improving in these ways. How do you move this data forward to collect better data to prove what you're doing and to make it change patient care?
Yeah, I think that's a really important question, and something that I've been thinking a lot about in general in terms of how to best sort of maximize the translational opportunity for these population databases. I think some of this, it's sort of a longer vision that, you know, will take probably some time, would be to find ways to better link and institute a provincial wide linkage of the imaging and possibly patient reported outcomes after treatment to these data sources available, because the imaging is there and it is used. You know, we have systems to transport imaging between hospitals across the province, and there is a repository available, but it's not quite been linked yet. And obviously there's issues around, you know, intellectual property as well as patient confidentiality. But I think incorporating imaging would be the first step, and then finding a way to follow these patients and you know, administer patient-reported outcomes would be an important next step for translational perspective, because I think identifying them would be helpful from these databases, but then being a way to then follow them prospectively would be an important next step.
Yeah, I mean, I think it's a real challenge that we need to find a way for these rare diseases where good decisions are made before the patients are treated. You know, a lot of these patients will have some sort of surgery, and by people who maybe shouldn't be doing it or maybe should be doing it, and then we're playing catch up with what the next steps are, because they don't even come to an MDT until after that first decision is made. And I think that's a real challenge for these diseases with the data that we have. If we think there's a right way to treat it, how do we make that happen before, you know, before the patients start off on the wrong path? And that's a super big challenge for rare diseases all over the world.
I'll just add one quick thing. Of course, the other issue that I don't ever know how to get around is you want more granularity in your data, right? Because even though it's a very rare disease, it's a very heterogeneous disease. So I can't recall a chordoma that did not get radiated at our institution in the last, I'm going to say 20 years. You know, it used to be if it was localized in the sacrum and you could do a complete sacrectomy and not violate the capsule of the tumor, potentially that was a curable tumor with surgery, but everybody else gets radiated. So I think there must be some differences in both degree of surgical resection and could there really get negative margins and those kinds of things. And it's always a problem looking at population-based, even the SEER database or all these other administrative databases that we have available in the US, for instance, that don't give you any actual data. So, I think you're going about it the right way, concentrating on one province and 12 centers. I think you can get further than just looking at some of these other big administrative databases.
Great, thank you. Wonderful discussion. We'll move to the next speaker in the interest of time, and then maybe at the end, if there's additional questions, we can open it up to the audience. So Kyle, if you're okay to share your screen.
Yeah.
Great. So Kyle, apologize if I mispronounce this, but Tuohy?
Tui, yep. That's good.
Tui. Fair enough. Is a fourth-year neurosurgery resident at Penn State Hershey Medical Center. His research interests include optimizing the use of intrathecal chemotherapy, which he'll discuss in his talk today, for leptomeningeal disease, and leveraging CSF liquid biopsy techniques to improve the diagnosis and prognostication of primary CNS malignancies. So all yours, Kyle.
All right, thank you. Thanks. Hopefully you can all see that. First of all, I have to apologize for my attire. This is an OR day for us. So I'm in between. Had to step out for a case. I did have a nice dress shirt planned, but didn't have time for it. Sorry. But yeah, I'd like to talk today about some research looking at the prevention of Ommaya reservoir infections with the use of prophylactic intraventricular vancomycin. Let's see if we can move this along. Oh yeah. So these are my objectives for today, real quick. Trying to look at if we can be doing more to prevent these infections. Specifically looking at, like I said, prophylactic intraventricular vancomycin, the efficacy and the associated costs and potential toxicities associated with its use. So I don't know about you, but for a couple of years, I used the Ommaya reservoir without knowing really where the name came from. But after doing some background research, it's from this gentleman here, Dr. Ayub Ommaya. He is a Pakistani American neurosurgeon who invented this device. He worked for the NIH for a long time in George Washington. In the late 60s, early 70s, he published an initial report and then a case series looking at patients that he treated with this device using chemotherapy, but also some patients got antibiotics for meningitis and also analgesics for pain. A lot of the complications then were he had a high number of hemorrhages. Stereotactic imaging was not what it was back then as it is now. So it had a lot of hemorrhages, which nowadays it's a lot safer. Placement's a lot more accurate. So that is not as big of an issue as it was historically. But one issue that continues to be a problem is infections, and those can have a high morbidity for patients who have Ommayas. As we know now, Ommaya reservoirs really changed the way I think that we introduce intrathecal chemotherapy for patients who require it. But reservoir-associated infections still remain. That rate is still pretty high, and it's not helped by the fact that a lot of these patients are immunocompromised. Prevention that we had historically done, I think a lot of institutions will do, is obviously preoperative antibiotics and then sterile procedure for injecting chemotherapy. But we wanted to know if there was potentially more that we can do to prevent these infections. And what we had thought we could try based on anecdotal evidence and looking at feasibility of doing this from historical research on shunts and EVDs was, can intraventricular vancomycin administered with each dose of chemotherapy reduce the rate of infections. And the way we had studied this, it was a cohort study with a retrospective control. A year after we changed our practice here to administer prophylactic vancomycin, was from May, but the beginning of that was from May to April 30th, 2021 to 2022, where we began giving 10 milligrams of vancomycin to each patient during their chemotherapy administration. And what we did is we compared that to a retrospective control for the past 5 years of patients that we had treated not this way. And this is how we defined a diagnosed infection, sorry. And our primary outcome was infection rate, whether it be per patient or per access of the Ommaya reservoir. And secondary outcomes were the rate of toxicity noted and the cost associated with the vancomycin administration. And this is just our procedure. So how do we do things? So this was all the same for both cohorts, with the exception of we would introduce the vancomycin after the chemotherapy and then flush that with some of the patient's autologous CSF. But other than that, the administration of the chemotherapy itself remained the same for both groups. So we had, between the two groups, we treated 63 patients in the 12 months quote-unquote study period, and compared that to 322 patients that were treated in the preceding 5 years. This is a comparison between those groups. Obviously, being retrospective, there's some differences between, notably tumor histology and the number of cycles. There was more cycles in the prophylactic group of note, and then interestingly more hematologic malignancies in the treatment group. I think part of that is just related to the patient population changing a little bit, but it's important to note those differences between the two cohorts. These are our results. We were fortunate to have no infections over that from patients treated in that year. They were followed for at least 12 months, so they did not have infections. At least our definition was no infection at least 12 months after their last access. The infection rate for the retrospective cohort was 10%, which is per patient, and then 1.7 for over 1,900 treatments that they had total over those 5 years that we administered. The attributable risk reduction for that then would be 10.3, and the number needed to treat would be 10. 10 patients treated with prophylactic vancomycin to prevent one infection. And we didn't observe any treatment-related toxicities associated with vancomycin, especially the biggest concern being ototoxicity. These are our costs. I can show you how we derive these, but the cost of the vancomycin over the course of 12 months, vancomycin, unfortunately, is pretty cheap now, was about $5,500 compared to the cost of what we had estimated for those almost 7 infections that were prevented over the course of the year. And so you can see the difference there. About $700K compared to about $5,500. And then this, we did look at some prior studies. I don't want to say this is a formal meta-analysis, but it was a review of prior studies that looked at infection rates, because our cohort that we looked at retrospectively was a retrospective cohort. So you can argue, you could say, well, want us to know how that cohort compares to previously published cohorts. So you can see the infections there that we had found, at least previously published in the literature. I will say our cohort had a little bit of higher infection rate, but that's sort of the rates we had noticed in the literature, just so we can have that to refer back to. Oh, and this is how I don't want to spend too much time on this because I don't want to go over time, but this is how we estimated our costs. So based on our cost for an infection, and that was, so it was $88,000 per patient we estimated. So that might change per hospital. So that's gonna be hospital specific. And then, and so our conclusions, I think this is pretty compelling evidence to at least suggest, at least from retrospective group, that prophylactic vancomycin can help reduce the rate of Ommaya-related infections, and it's certainly cost-effective and not seen to have any added toxicity. Some limitations to our study, of course, retrospective being the biggest. There were a higher number of accesses in our vancomycin group, although I think there's some conflicting research in the literature as far as whether or not access itself is a risk factor for infection. Not sure what the optimal dose of intrathecal vancomycin would be. We use 10 milligrams for everyone, just to, we don't want to add too many variables to the equation, but it's possible that more or less even could be efficacious. We did not have long-term follow-up for everyone. Everyone had at least 12 months, but some had more. Some had just barely 12 months, so important to consider. And then I should mention, full disclosure, we've had infections since then. Prophylactic vancomycin is not going to cure Ommaya infections or prevent them overall, so they're going to happen. But I certainly think, as what we've seen, is to a much lesser degree than what we've seen before the change. I have to thank these folks for helping. I mean, it'd be huge help, especially the mentors towards the end, Dr. Zakaria Mansouri on the neurosurgical side, and then Dr. Argawi and Dr. Glantz on the medical neuro-oncology side. It's a big thank you to them. And that is it.
Lovely. I love this last slide.
Thanks.
Thanks for your presentation. So I'll open it up. Maybe Dr. Link or Dr. Drummond, if you have a question.
Yeah, I think this is fantastic, I have to say. Uh, and I think you've done a great job of trying to answer this question. A couple things that kind of intrigue me about this is for many years, I was actually on the infection surveillance subcommittee here at Mayo Clinic, where we would meet once a month and go over each department's infection rates. And every now and then there would be a spike. So we have, our institutional data, we had national data, and every now and then, like for instance, so cardiac surgery would have a spike in their infection rate. And then one of us was tasked with going to their departmental meeting and saying, hey, you've had a spike. Do you have any idea why? And of course, the answer was always no. We never had any idea why. And they would grumble a bit about, oh, your data has some problems in it, I think, and so on and so forth. But next quarter, their infection rate was near zero. And then it would happen in, liver transplant surgery or neurosurgery or ENT or something. And so I think maybe some of your effect is you were actually doing a study looking at infections. So compared to your retrospective cohort, I think it was probably in the forefront of people's minds. It doesn't discount your work, but I think that has to be taken into account. The other thing I would ask is, from time to time, I've had either shunt infections or CNS infections, and we have an EVD in place. And I've always wanted to do intrathecal antibiotics. And our ID people will often say, we don't want you to do that. And I've never gotten a good answer to it. So I'm a bit impressed that at your institution, they were okay with you doing that.
I'm happy to address some of that if you don't mind. You're right, and one of the authors there was our head of pharmacy, so it was a PharmD, Dr. Levitt, and so he certainly had big help from him having buy-in to do it, because, like, as you mentioned, and I should have mentioned that this is an off-label use for vancomycin. Had to mention that it's not FDA approved for that. So yeah, you're right there. And then you are right. We were probably more hypervigilant about infections, after those preceding 5 years. The best I could do to convince you that the vancomycin help was that at least over the past 5 years, one of the concerns was, what if our infections were just dropping every year? So the average rate was 10%, but what if it was, really high and then it was almost zero and then it happened to be zero? I could tell you at least the infection rate for every one of those individual years was 6 to 8. So there wasn't any of that. But that doesn't discount what you would say, because I think that's still true. But that's my only rationale.
I think, this could be a very good placebo study where, whoever is doing it doesn't know if they're injecting saline or vancomycin. And I think, that could really, I think, prove your hypothesis here. But anyway, I think it's great. Have you published it, or is it been submitted?
It accepted in neurosurgery, the Red Journal. I just got last week I got the email to look at the PDF, so hopefully soon.
Good. Congratulations.
Thanks.
Just one more comment so I mean, this is a pretty unique experience. There mustn't be many places that put in that many Ommaya reservoirs. So fantastic for obviously it's a practice pattern where you are, and fantastic that you've harnessed that data. Just one, you haven't shown that it's not toxic, because it doesn't look like you've done audiology sometime down the track. So you don't really know yet that it's safe, and it'll be hard to ever work that out, because many of these patients will have lots of reasons why their hearing might deteriorate, but you haven't discounted ototoxicity, which if the class action lawyers are anything to go by, they love to look for that. So
Yep, no, you're 100% right. It was all mainly subjective reports that the renters. You're 100% right. And as far as I think the reason we're able to do it was partly because of Dr. Link's comment at the beginning about finding opportunities for research where you are. You're right. We do place a lot. We have a large catchment zone in central Pennsylvania. There's a lot of hospitals in Philly, a lot of hospitals in Pittsburgh, but the center of the state, we're the only ones that can do this. So we end up, fortunately, putting in a lot of these for lymphomas and leptomeningeal disease. So yeah, we're just in a position, I think, to study it.
Wonderful. Thank you so much. Very interesting discussion, and certainly I echo both Dr. Drummond and Link's points, particularly when I saw your abstract regarding just the sheer amount of Omayas you put in for leptomeningeal disease is interesting. So it's great to hear about your project. So the next speaker is Rahul Kumar. So Rahul, if you can share your slides. Rahul Kumar is a PGY5 neurosurgery resident at the Mayo Clinic in Rochester, and he's planning to complete an enfolded fellowship in skull base with Dr. Link. And his research interests include studying genomics of brain tumors, including functional genomics, in which he has a PhD prior to his residency. So take it away.
Good morning. Can you guys hear me okay?
Yeah.
Perfect. So, yeah, I appreciate the invitation. It's a real privilege to have this opportunity to share our institutional experience with stereotactic radiosurgery as a primary treatment for sporadic intracranial meningiomas over really the past quarter century. I made no money putting this together. So for this group, meningioma likely doesn't need a terribly long introduction, but in brief, the majority of meningiomas are benign lesions where the treatment goals for symptomatic or progressive lesions span the spectrum from observation to a combination of surgery and or radiation therapy, where fractionated or single fraction stereotactic radiosurgery can be used. Safe and complete surgical resection can be limited by proximity to critical neurovascular structures and or just patients being sick or having significant comorbidities. And so stereotactic radiosurgery has emerged as a treatment modality with high tumor control rates and relatively low complication rates. However, in the literature, most of the descriptive cohorts are significantly confounded by lesions which have undergone prior resection and or radiotherapy. And so thus the goal of the current study is to leverage our extensive institutional experience with single fraction SRS as a primary treatment for meningiomas, meaning these are tumors that had not previously undergone surgery or radiation or any tumor-directed therapy. So we performed a review of 616 consecutive patients over a 25-year period from 1997 to 2002 that underwent primary SRS or gamma knife for sporadic meningioma. At our institution, we used single fraction gamma knife with the dosimetric parameters summarized in the table to the right here. Of note, our median margin dose was 15 gray, and radiographic follow-up was obtained over a serially increasing interval. The primary outcomes of the study were progression, either local, defined as an increase of greater than 2 millimeters from prior interval imaging, marginal, which was defined as tumor recurrence adjacent to the irradiated target, or distant. Local tumor control was defined as the absence of either local or marginal progression. And additionally, we collected data on the neurological sequelae after SRS, which were almost universally ascribed to treatment to mitigate any bias. This plot shows the constellation of presenting symptoms amongst our patients in our cohort, with headache and diplopia occurring in 24 and 15%. Of note, in this cohort, 2/3 of patients had incidental but radiographically progressive meningioma. And this plot shows the constellation of symptoms, this plot here shows the distribution of sizes for these tumors, with a median treated tumor volume of 4.5 centimeters and 653 tumors, the vast majority of which were skull-based in location. At a median radiographic follow-up of 6.3 years, 50% of tumors just decreased in size, while 49% remained stable, yielding a raw tumor control rate of 98.6%. Local progression was noted in 7 tumors, or 1.1%. Marginal progression noted in 2 tumors, 0.3%. Distant progression was observed in 3 patients, 0.5%, whose treated tumor remained unchanged. And therefore, progression-free survival estimates at 5, 10, and 15 years were 99.8%, 99%, 93.2% respectively. And factors associated with progression included older age, male sex, higher tumor volume, and lower marginal dose on univariable analysis. Treatment-associated neurological sequelae were noted in a total of 56 patients, or just under 10%, of which the vast majority, 7.3%, were temporary, and approximately 1% were minor, and 1% were major, required subsequent intervention. Cranial neuropathies were the most common post-SRS sequelae, and of note, no patient developed a radiation-induced malignancy during the follow-up after SRS. Radiosurgical parameters demonstrating association with treatment-related sequelae and univariable analysis included increased number of ISA centers, a longer treatment time, a lower BED or biological equivalent dose, a higher V12 or volume treated to a dose of 12 gray, and larger tumor volume. Interesting, neither marginal nor maximal dose demonstrates statistically significant associations with treatment-related sequelae. And of note, there was an expected significant autocorrelation amongst these dosimetric parameters, and notably an inverse relationship between BED and tumor volume. And so, just to get into BED, kind of as to close off this talk, biological effective dose is essentially a model whereby the tumor kill rate after a dose of radiation can be estimated based on various dosimetric factors. And it's thought that this might be a reliable biomarker of tumor control because it more faithfully accounts for the intrinsic mechanism of tumor cell killing by radiation. And it's been shown in previous papers that this measure BED is potentially useful in predicting outcomes, whether tumor control or complications. In our case, we were really interested in the incremental improvement of, with a 99% tumor control rate, I think the area left for improvement is minimizing the amount of treatment-related sequelae in these patients. And unfortunately, at least in this cohort, you can see from this plot on the right that BD really did not perform any better than a flip of a coin in terms of predicting treatment-related sequelae. And so the hunt is still on for a better biomarker that we can optimize in terms of reducing these treatment-related complications. And so in conclusion, I hope I've been able to show you that single fraction SRS really works well for treating these meningiomas with a low rate of treatment-related complications and excellent tumor control rates. Larger tumor volumes were associated both with tumor progression and complications, which kind of underlies the suggestion that proper patient selection is critical, and I think intrinsic notion that surgical resection should really be considered for larger tumors or those with atypical imaging features. We advocate for the continued use of a margin dose of 13 to 15 gray, which we believe strikes a pretty reasonable balance in terms of tumor control and treatment-related sequelae. And at least in this study and in our practice pattern, biological effective dose was not an independent predictor of tumor control or treatment-related sequelae. And that model that we utilize may require further refinement specifically for its implementation against meningiomas. And key limitations in this cohort, obviously retrospective, so there was selection bias and incomplete follow-up. These tumors were treated on the basis of radiographic diagnosis since they had not had any prior treatment with no tissue available. So there was likely or potentially the inadvertent inclusion of some other pathologies, but I think amongst the 8 or so tumors that subsequently went on to surgery, all were shown to be meningiomas. At our center, we don't do routine volumetric segmentation, and therefore we were unable to identify conformity indices. And then kind of the other thing in this field, these tumors tend to be slow growing, and patients are younger at diagnosis with the increased frequency of cranial imaging. So many of these patients had life expectancies well over 20 years at the time of diagnosis. So even with our long follow-up, we still haven't truly captured their spectrum of life in terms of saying, how this affects them from the time of diagnosis to the time of a natural death. And with that, I'd like to thank the people who helped this study happen, particularly Dr. Pollack, Dr. Karlstrom, and Dr. Link, and our colleagues in radiation oncology. So I'd be happy to take any questions.
Thank you, Rahul. Great talk. I think maybe we have time for one or two questions, if any come to mind for Dr. Drummond or Dr. Link. I know Dr. Link, you're on the study, so might be a
Can I ask, you had one of your complications as headache. Everyone's got a headache. How did you tell which headache was related to the treatment?
Yeah, we were, I think, quite stringent in the fact that if a patient came for follow-up and had a complaint of a new headache that had emerged since treatment, we ascribed it to radiosurgery. And I think in some of my sub-analyses, I think those headache symptoms were not statistically correlated, but trended with the existence of preoperative edema, which I think might be expected, as well as stratified by location. So I think likely with a little bit of swelling next to the dura, I think it may have predisposed certain patients to headache. But
Okay.
yes, you would assume after everyone gets a head frame clamped on that they might have a headache.
And you didn't mention location much in your results, so that wasn't an important predictor in the end?
In the end, not particularly. We came in with the hypothesis that, especially for treatment-related complications, skull-base location would potentially be a significant association given proximity to cranial nerves and otherwise. But I think the thought may be that those convexity tumors had their own host of complications in a distinct profile from those of skull-based tumors. So, for example, headaches, seizures, etc., are probably more likely with convexity tumors. So the overall effect was probably null between the two.
Thanks, great study.
Thank you.
Okay, thank you so much. So that concludes the trainee speakers. I think we have Arushi, who has joined us on the panel. Arushi is a PGY6 neurosurgery resident at the University of Michigan, who has a study ongoing that would benefit from your participation. So Arushi has shared her slide, and please let everyone know how we can help.
Thank you for the introduction. So like he said, I'm from University of Michigan, and I'll jump right into it. We've all taken care of patients with brain tumors, and 10 to 20% of them end up hemorrhaging due to a variety of patient-related and tumor-related factors. And a lot of the patients have also a coinciding medical indication for antithrombotic therapy, whether that's due to their cancer or because of the increased age in patients with cancer, atrial fibrillation, or other causes for venous thromboembolism, whether historical or concurrent with PEs in the hospital. So we always write, all of us have written tons of notes and given recommendation on these patients who have brain tumors that have hemorrhages and also need anticoagulation. And we're consulted on these patients and are given the opportunity to provide our recommendations. And unfortunately, brain tumors are usually excluded in clinical trials, so our guidelines for management in these situations are lacking. So we wanted to study what are the practice patterns of neurosurgeons and hematologists in North America when handling patients with brain tumors that are hemorrhagic who also need anticoagulation therapy. So when do we start those patients on anticoagulation, and in which situations is it safe to restart, and at what time point? We're also concurrently doing a study regarding the factors associated with the hemorrhage and resumption of anticoagulation therapy at the University of Michigan. But this is the survey portion specifically for attending neurosurgeons handling patients with brain tumors. There's a $30 gift card if you take this survey. I think it's really, really important for neurosurgeons to be taking this survey. We're collaborating with various hematological associations, ASCO, ISTH, NCCN, on this project, and we're getting tons of responses from hematologists, but we also need to get the opinion of neurosurgeons, as the factors that we're considering as neurosurgeons are slightly different. So we want to get a broad overview in order to help the ISTH formulate their next guidelines for anticoagulation therapy in brain tumors.
Okay, wonderful. Thanks for sharing your slide, and this will be recorded as well, so hopefully others can see it who aren't here live. So with that, I would like to thank all those who have attended for the sessions, the speakers, Rahul, Kyle, and Hussein, and our faculty discussants, Dr. Drummond and Dr. Link, for your time, your engagement, and the interesting discussions that were had. We will be hosting another one of these sessions in a few months, so I look forward to seeing you back here, and we'll have another call for abstracts for anyone who's interested in sharing their research at the next session. Thank you all.
Thanks, everybody.
Thank you.
Thank you.